So, Allie, tell me a little bit about the aspect of emergency treatment that you would consider most important. What are the issues that that we have to have in our head? We have to have a comfort zone with before we begin this emergency treatment, whatever that emergency treatment may be.
So emergency treatments are basically classified as those types of procedures in which a patient is unscheduled, they come in pain, and you're trying to address their pain, right? So the problem that is associated with that is a matter of time because you're trying to fit somebody in when you don't have enough time. So you want to be efficient. Therefore, the key to treating these things properly is proper diagnosis and proper treatment plan for that given patient. So that's the real key component of all emergency treatment as to what is wrong, what is the cause, the source. That's the diagnosis. And again, the key here is to make sure that unless you have a proper pulpal and apical diagnosis, not to touch the tooth for any kind of an emergency procedure. Many times patients come too early before a problem is localized, and in those cases it's best to wait. So not to get overzealous with addressing the patient's pain without being sure.
So if you can't reproduce it.
If you can't reproduce it, you at least have two signs in order to have a proper diagnosis. It's not the time to treat it. So, we go through this in detail in our diagnosis course, and I think that's a really important part to keep in mind before doing anything to a patient who comes to you in pain and is unscheduled. So that's the key thing. And then we need to kind of treat the case based on the diagnosis. Then we have to decide what we're doing.
I know that treatment entails particularly either a pulpotomy or a pulpectomy. Question comes up all the time. When do I do one? When do I do the other?
Right.
Can you guide us a little bit on what you use as the parameters of when you do one or the other?
Sure.
And what they are?
Sure, definitely. I mean, there's basically four options for a treatment of patient who is, having pulpal issues that maybe are emergency procedures, whether you do a pulpotomy, you do a pulpectomy, or you may do an incision and drainage if it's an abscess tooth, or you may have to punt the patient, whether referred to an endodontist for a little bit of more time and better diagnostics, or it just is not clear at this time. Nobody can figure out, even an endodontist. I sometimes have to send the patient back to wait a few days more till things localize. But basically, how do we determine, let's say if it's a pulpotomy, pulpectomy, or an incision and drainage, if we know what tooth is involved, is in cases where you have early irreversible pulpitis, where the inflammation is confined to the coronal pulp, and it hasn't actually reached the radicular pulp yet. Or in cases in which let's say you have a patient that has deep decay, it has signs of reversible pulpitis, but it's very, it's kind of borderline deep. So you decide to just remove the decay and see what you can do, and you end up, basically getting into the pulp because the decay was just so massively large. In those cases, a pulpotomy will suffice because the radicular pulp, the pulp that's beyond the orifice of the canal, beyond the CEJ, is still not inflamed. And in those cases, a pulpotomy will suffice. If the radicular pulp, which is the pulp that is beyond the CEJ, apical to the CEJ, is also inflamed, infected, or is in fact necrotic, the only treatment that you can do would be a pulpectomy. And that means that you basically are trying to remove the pulp as close to the full working length in the apex as possible. Okay. So that would be a pulpectomy. And if in cases where you have a large fluctuant abscess that is, that could be incised, then an incision should come in with the pulpectomy as well. I mean, the pulpectomy is a definitive treatment. The abscess drainage would be the kind of the palliative treatment, because you always have to address the source, and the source is in these cases that we're talking about, are odontogenic and they're coming from the pulp. So you need to do a pulpectomy at least in order to get the proper results.
Okay. So how do we do it?
How do we do a pulpotomy and a pulpectomy?
Yeah.
Well, the pulpotomy is basically your endodontic access up until you reach the orifice of the canals, right? So you remove the tissue, the pulp, using very sharp burrs. That's a really critical thing. You want to have new sharp burrs to remove the pulp, because if you have dull burrs, you end up pulling on the pulp, and that ends up pulling and severing and injuring the pulp that's in the radicular pulp that's beyond the CEJ. So it's really important that if you're using a burr or a spoon, that they're both very sharp. Then you want to take it up to the orifice of the canal and no more. So that's a critical thing. A lot of people say, well, maybe I could put a little bit of a file in there and see if I have a canal or not. So can I do this root canal myself or not?
Yeah.
No. If you put a file in there, you're committed to do a full pulpectomy. And what a pulpectomy is basically the initial phase of your cleaning and shaping procedure, which means using files and instruments to get down as close to the apex as possible. Usually you could be within 1 millimeter or 2 of the apex and you're fine. So you don't have to have that kind of accuracy in order to get the full working length measurement. But that would be ideal. If you have the time, that would be the way to do it. So I use the ESX instrumentation system. So for most of the cases, I end up using 2 files, just the main expediter file that's used at the beginning, and then the size 25 will usually suffice. If it's a very big, juicy anterior premolar, I may use a 35 or a 45, the other 2 finishing files in the ESX system. But it's the beauty of a system that's efficient like that is that you only need 2 files, and the vast majority of time, with those 2 files, you can get the results where the patient's comfortable. And then you place calcium hydroxide in the canal because oftentimes, emergencies are a matter of time constraint, right? So you won't generally have enough time to do your full cleaning and shaping and obturation. Of course, if you do have enough time, you can do it, unless you have a draining canal.
So on an emergency basis, would it be fair to say that the most ideal pulpectomy would in fact be full instrumentation?
Without a doubt. I mean, if you instrumented to the full thing before obturation, that's the ideal.
Pulpectomy.
The perfect pulpectomy is cleaning and shaping. Procedure right before the obturation. Like I said, though, unfortunately, it's a matter of time. You get patients that come in with maxillary first molars and second molars where you got all this MB2, all these other canals that are difficult to find. It takes considerable amount of time. If you have the time, no question about it, do it. But if you don't have the time, if it's a pulpotomy, make sure you stay at a pulpotomy. Do not put a number 10 file in the canal. If you put a number 10 file in that canal, you got to get it to a size 25 at least. Remove enough pulp to make it. Otherwise, that patient's going to be in more pain, actually,
That's actually that's the patient who calls you that night.
Exactly.
And it doesn't work well for anybody.
Yeah. It's basically stabbing the pulp, and that's not the way to do it.
Think of it in terms of a wound, and you go in and poke at it. And then leave all the infected tissue or any of the, it's not good.
Yeah, so for pulpotomy, calcium hydroxide on the pulp stumps, and then restore with a cotton and cavit, and then have the patient come back. For pulpectomy, calcium hydroxide in the canal, and then cotton and cavit, and have the patient come back.
And calcium hydroxide is very easy to remove.
Calcium hydroxide doesn't set.
Doesn't set. So it's easy to remove thereafter.
Yeah.
So, Ali, you've talked about a couple situations, all of which are essentially intact pulps.
Yes.
How do you deal with an emergency of a tooth that has been previously treated?
Previously treated teeth are more of a challenge because you have to quickly make a proper diagnosis and a treatment plan because you need to figure out what are you going to do with a tooth that has had a previous root canal and it still has an infection. Is the problem going to be addressed with a full non-surgical retreatment, or would it be surgical with an apicoectomy, or would it be an extraction? So there's a few different options. So based on that, you would basically be addressing the emergency component of it too. But if it's a retreatment where most of the cases end up being or should be, because most of the endodontic cases have failed unless this was a serious problem at the apical area and there was a procedural error with a ledge or transportation or something like that, because of coronal leakage. So in those cases, you want to do a retreatment. So you got to have enough time to get in there, access, remove the tissue, remove the gutta percha that's remaining in the tooth, and get drainage through the tooth. So that's a little bit harder. So those are usually cases that the endodontist would have to be, because they would be a little bit more efficient at doing a retreatment. So when you have a previously endodontically treated tooth that is failing, it's got an infection, that would be a retreatment to the full extent, get drainage, and then place calcium hydroxide. and then have the patient come back. If you end up having to do an apicoectomy, you can actually do the apicoectomy at the same time, same visit, very quickly. Nowadays, again, using the bioceramics for apicoectomies are very quick. It takes me less time to do my apicos than it takes me to do my non-surgical root canals.
Oh, sure.
So it is that's another thing to do as well. And if it's an extraction, then obviously that has to be properly triaged. But a lot of people just give antibiotics. And we're going to talk about the antibiotics a little bit in more detail, but that's not the right approach here, because a lot of times, especially in emergency cases, you give the antibiotic and that masks the problem. Especially if you're not going to treat the patient, then you want to give them the antibiotic and you send them to the endodontist. If you haven't had a diagnosis already, you just don't give a patient the antibiotics, because that could mask a problem and that would be an issue. But let's go back. Let's not get off the subject, because we're going to talk about antibiotics a little bit later. Little bit later. But let's look at this tooth, for example. This premolar had a previous root canal, came in an emergency. We had to kind of remove the whole pulp, get in there quickly, get down to the end, get a little bit of drainage, put calcium hydroxide, and on the right side, the tooth is treated. Actually, the tooth behind it also ended up needing root canal, so it was then treated at the same time on the second visit. But on the first visit, we had to get in there and actually remove the whole root canal filling material, put some calcium hydroxide dressing, and then see the patient on the second visit. And since the other tooth was actually necrotic too, but it wasn't painful, but then we just did both of them at the same time.
That wonderful lateral canal.
Yeah, we got a little,
cuspid. That's really.
That's right. It was a little bit of a lateral canal
BC
that popped.
Sealer?
That's BC Sealer. That's the hydraulic condensation technique with AES-X, which we will talk about in our obturation course. Lastly, when you have cases like this, molar, second molar, you would either be doing an apicoectomy, but this is a second molar. You got a patient, as I remember, this was a young patient, had lots of pain. You can't do an apico that quickly on a lower second molar, right? And this patient doesn't want to lose their tooth. Here's a good situation where we did a intentional replantation, put the tooth back in, and you can see the 6-month recall X-ray on the right side. Intentional replantations are very helpful. Of course, they have specific indications, and this is like the perfect indication for it to do a case like that.
So you have an abscess tooth. The person comes into the office, it's diagnosed as a abscess tooth. What are you going to tell our audience to do in that case? So
first of all, anytime a tooth has an abscess or swelling, the first and foremost, you got to do the pulpectomy, because you have a necrotic tooth, obviously. You have to have a necrotic tooth before you have an abscess. Okay. So you have to do a full pulpectomy in those cases. If the abscess is large enough and fluctuant enough, you can do an IND as well. Whether you put a drain or not is controversial. If you've done a pulpectomy, there's absolutely no reason to put a drain in there. It's just a higher chance of getting infections because of the drain. The drain thing is kind of... It's no longer in fashion. So you would do that only for patients that have fluctuant swellings and so on. And then the use of antibiotics is another important thing. You only should give antibiotics if the patient is febrile and has systemic signs of infection. If it's a local infection with swelling and abscess, as long as you've done the treatment, the definitive treatment of pulpectomy, there's absolutely no reason to give the patient antibiotics. You can actually harm them more by giving them the antibiotic.
All right, so just help me with this. Person has a cellulitis.
Yes, cellulitis is a little bit different because that's more of a widespread infection. Okay. You can give them...
Are we calling that systemic, or is it really more...
Well, more widespread, and depends also on the location and so on of it, whether it's in the maxillary and it's kind of spreading along the fascial space in the canine infraorbital space and the canine space, or, you end up getting deep into the submandibular space, then you may consider giving the antibiotic in conjunction. But for the typical vestibular abscess that you see most of the time, that's the run-of-the-mill stuff, the antibiotic is not needed as long as you've done treatment. But the key is to do treatment, not to use antibiotics as a crutch, because there's so many negative consequences of antibiotics that we now know that we should not use them unless they're absolutely positively necessary. And some of those cases where it's very important is in cases where there is fascial spaces, widespread fascial spaces, you get Ludwig's angina, things like that. You got to send those patients immediately to the emergency room. Yeah, sure. And that's cases in where the patient also has trismus. Trismus being the kind of a locked jaw means that the infection has usually traveled into the fascial spaces and includes the muscles. The muscles in spasm and creates trismus, which is the mouth that can't open. The fact that you can't take an X-ray of a patient like that, is not an excuse legally for you to just give them antibiotics and punt them, right? Yeah. Those cases should be immediately referred to an endodontist, and you could take a Panorex to find out which tooth it is. And also, I mean, the clinical testing is enough to find out what's the cause. Just without even an X-ray, you can find out if a tooth is necrotic or not by doing proper pulpal testing. All right, so let's come back and actually show a full demonstration of the emergency procedure that you can do on a premolar tooth.